Good morning. When I was first asked to participate in this forum, I was a little bit unclear about what my role was supposed to be. I'm just a dumb ID doctor from Texas. And as you can see, my academic affiliation is Texas A&M, so I'm supposed to say howdy rather than good morning. But as I reflected on the IOM report that you have, and I reflected on my work with sepsis and stewardship, there are a number of parallels which I'd like to bring to your attention. Just like with cardiac arrest, we want to look at early recognition, the changes in vital signs. We want to look at prevention. We want a way to do some risk-adjusted outcomes, which are very similar to what you have expressed here this morning about, about cardiac arrest. And just like you, we can go on two pathways. We can put our head in the sand and wait for a crisis to develop, or we can come up with some successful strategies proactively instead of waiting for the regulatory levers to force us. And many of you in this room, I'm sure, are familiar with the IOM report, Crossing the Quality Chasm, which tells us it takes us 15 to 17 years to hardwire best practice. That's far too long, and our patients deserve better. Now, I love what the first speaker said. He talked about the culture of inaction and developing collaborative action. Well, here's two front-page articles from well-known lay publications. Newsweek in 1994, Antibiotics, the End of Miracle Drugs. Are we truly entering into a post-antibiotic era? And here's Consumer Reports over 20 years later. And we've unfortunately done very, very little. And one of the things the IOM report recommends that you have to have action through public awareness. And this is exactly what these magazines were trying to do. Most of you in this room know that there's a great reason to improve antimicrobial use, just like it is to improve outcomes from CPRs and early recognition. There's overuse and misuse. There's tremendous overuse in animals, which is a whole nother discussion for another day. There's significant adverse impacts on patients and societies, and the societal cost of antimicrobial resistance and sepsis are significant. Many of my colleagues have been confronted with pan-resistant untreatable infections, which is a scary thought. If you think about the major advances in public health over the last century, we think of vaccine-preventable diseases, and we think of the discovery of antibiotics as being major advances, and in both those areas, we've seen some falling back, and that's a serious thing to consider. And this is a worldwide problem. Antimicrobial resistance does not know country boundaries. And the World Health Organization considers antimicrobial resistance an emerging threat to global stability. With global travel, I think, how many people here have heard of Ebola? I think you know Ebola is just an example. But this is a complex problem. Anytime we have to talk about changing physician behavior, it becomes more complex. We got some help from the PCAST report, the National Action Plan for Combating Antimicrobial Resistance, which came out last year. And one of the things they discussed in terms of public policy, and it gets to your recommendation number 4 of developing and implementing accreditation standards, they did recommend aligning with the CDC core elements, we'll talk about in a minute, and compliance with conditions for participation of CMS, and working with the Joint Commission Accreditation Standards and implementing this, and also implementing annual reporting, which is sort of like a registry, which is one of the other recommendations that you made as well. This is the core elements that came out in 2014 from the CDC. These are not particularly unusual. Leadership, and I have to tell you, leadership at the highest level of the C-suites is necessary. You want to appoint a single leader responsible for outcomes at your institution. You want a single pharmacy leader. You want to be able to track things. You want to educate providers, not just providers, but also patients and families. And you want to look at specific improvements and intervention to see whether or not things are working. Very similar to what you're talking about the last 2 days. And there's a lot more people at the table now in stewardship, as you can see on this particular diagram. At the top right is the White House. That is the PCAST report. You see the Joint Commission at the bottom, and you see CMS there on the right. These are all folks that can help drive improvement You see the American Hospital Association, many key societies, all involved, and also the National Quality Forum, and I'll talk about its role in just a moment. So let's talk about the playbook. What's the concept of a playbook? And then we'll show you how we took something and hopefully made it actionable. We wanted to provide guidance and strategies to implement and sustain a successful stewardship program, which is ASP. You could say the same thing for resuscitation. What does success look like? What are the strategies to address barriers to implementation? And what are the survey standards to determine if, in fact, a program is truly substantive and has meaning based on the CD key core measures? And hence, the origin of the antimicrobial stewardship in acute care, we call this a Practical Playbook, which is a National Quality Forum, National Quality Partners, and Antimicrobial Stewardship Action Team. So the playbook was developed over about a year. It brought together public and private sector leaders, experts to develop common agenda, identify and implement strategies to improve practices among providers, healthcare organizations, and local communities. It sounds very similar to what you're trying to do here in the last 2 days. The playbook makes recommendations for organizations including hospitals, accreditation bodies, and I have to emphasize that if you really want to drive care, talk about the regulatory levers. And you want to engage patient and consumer groups, which we did, because I tell you, consumers can be an awful, very good advocacy group. The playbook attempts to lay out implementation examples over a broad range of what is possible and achievable, while recognizing that what will be effective heavily depends upon local circumstances. We all know that it's execution at the local level that really makes the difference. So based on the core elements, the playbook provides concrete strategies and suggestions for organizations committed to implementation stewardship in acute care hospitals. You could put in CPRs in there as well as stewardship. The playbook incorporates successful implementation and more specifics concerning at least our core elements. It could be your IOM recommendation. Barriers and solution for implementation. We thought this was important, and I'll show you how we developed the playbook in a moment. Potential measurements and then future directions. The playbook was not designed to be a must-do to be completed. Instead, it was an attempt to lay out a variety of options from which to choose depending upon local context, resources, and needs. Now, here's just a partial list of the action team organizations that from very prominent hospital organizations, which you can recognize, AHRQ, you can see the regulatory group, Premier, Pew, and many others were all involved. There were some 30-plus organizations that came together to put together the playbook. So here's the timeline. We started in March of 2015. We had a kickoff virtual forum in May of 2015. The providers and payers were involved. We had a tweet chat, and you got to do social media. We developed a playbook to advance stewardship that we had an in-person, face-to-face meeting in December where all the stakeholders got together, came up with what actually was the format that we actually published. We had a breakout session at the annual NQF meeting in April to preview the playbook and get feedback, and then we actually launched it on May 25th. We're now in the process of debriefing and looking at next steps, and because of the success of the playbook, we're thinking, in fact, we're planning on doing the same thing for long-term care, which is badly needed. What do I think the value of the playbook is? How could that fit into what you're doing? Gathering national experts in diverse healthcare backgrounds in leading organizations to reinforce that stewardship is a national priority. Substitute what you're doing here today in terms of CPRs. Indispensable tools that align perfectly with the CDC core measures, the new Joint Commission Accreditation Standards, and now the proposed CMS conditions for participation, and provide examples and suggestions for action. And here's a key thing, regardless of size and resources. And it was mentioned earlier this morning, a lot of CPRs are not done in true children's hospitals, and I think you have to adapt for that. And that the stewardship is a key resource, and the way it was laid out, it went from the basics to the more advanced, and in each section it had URL links to critical resources to help you succeed. We've had over 8,000 hits on the Playbook, and it's been an extremely successful and a very satisfying experience. And with that, I'll stop, and I guess we're up for the panel.